Well, good afternoon. I want to welcome you to the Institute of Medicine of Chicago, a session on the state of health of Chicago. This session is the 20th session of the 8th convening of the State of Health of Chicago. My name is Lorenzo Pence. I am the Secretary of the Institute of Medicine of Chicago and Senior Vice President for Osteopathic Accreditation at the ACGME. Here's a snapshot of our agenda today with our panel speakers. I think we have a wonderful program set for today. This agenda includes a panel discussion, question and answer period, and updates on future programs and speakers. Today's session provides a summary of the past 15 months of virtual sessions related mostly to COVID-19 and collaboration in the time of the pandemic. As you note, we have a number of objectives, including safe healthcare and public health grade for Chicago and the state of Illinois for the performance during COVID-19 in several specific areas such as childcare, youth, mental health, maternal health and morbidity, opioids, and senior care. The audience today will be able to identify improvements made over the past 2 years in Chicago and the state of Illinois, and also apply and relate to the potential improvements that will be suggested to improve policies, systems, accountabilities, funding mechanisms, addressing deficits, gaps, etc., to foster systematic change during a pandemic. Next slide, please. On behalf of our Board of Governors, we welcome you to today's section on State of Health of Chicago. Thank everyone for wanting to participate. IOMC's mission is strong, and we are confident in our efforts as we go forward. We are celebrating our 106th year, and in June, we will have reached our 107th year as an organization. What a wonderful milestone. IOMC is an independent, nonprofit organization of distinguished leaders in the health fields who collaborate to improve the health of the public. We are proud to draw upon the diverse membership and other regional leaders to address critical health issues. Next slide. Before we get started today, I would like to share a few upcoming events. Please save these dates on your calendar. In February, we will address mental health and during the COVID pandemic. In March, we are addressing homelessness and crisis as a public health and healthcare issue. In April, we are partnering with Rosalind Franklin with intersectionality of education and community engagement. In May, we are addressing chronic kidney disease and its disparities. So just to note, it's important to note that in April, the April program will be hosted by Institute of Medicine of Chicago and Rosalind Franklin University. There will be 4 virtual sessions addressing the intersectionality of education and community related to healthcare, trends in career and trends in careers. Look for more details next month. This special series will include over 20 speakers. On June 24th, we will host the 2022 annual meeting at the venue 610. We are planning an in-person event. Please save that date on your calendar. And at this time, I would like to thank all of our sponsors for support of the entire program, State of Health of Chicago, for the past 15 months. With their support, IOMC has been able to offer these sessions for no charge. Starting with Blue Cross and Blue Shield of Illinois, Northwestern Medicine, Rosalind Franklin University Medicine, University of Chicago Medicine, the Portis Foundation, Michael Reese Research and Educational Foundation, Washington Square Health Foundation, Hectone Institute, Complete Care, Aunt Martha's Health and Wellness, Care Advisors, and Golden Square. Again, we want to thank all of our sponsors for all they do, and thank you for your support. So at this time, I would like to formally introduce Dr. Cheryl Rucker Whitaker, our president and chair of the Institute of Medicine of Chicago and CEO of the Complete Care Partners, LLC. We'll keep all our introductions short to allow for more time for today's program. Please see their website for more details on our speakers today. Dr. Whitaker.
Thanks so much, Lorenzo, for kind of kicking us off this morning. We're hoping to spend the next kind of 30, 35 minutes kind of having the panel present on their various areas that have been identified as kind of pressing areas, if you will, for kind of healthcare improvement in Chicago, in the Chicagoland, if you will, Cook County, broadly speaking. And then we'll have a discussion and opportunity for a question and answer. So, I've asked each one of the panelists to cover some specific topics, and then they'll kind of do their grade of how they think we're doing, and then what are the opportunities to improve the systems that that underlie some of the disparities and health inequities that we kind of continue to see. Over the last 2 years, it's been a challenge for our system overall, meaning that any deficits that we had were, exacerbated by the COVID-19 pandemic. So I start with that as our kind of umbrella, if you will. The COVID-19 pandemic that brought kind of an unforeseen, unprecedented event to Chicago, and to Cook County, and really to the state of Illinois, and to all the citizens, to all of us who are practitioners of healthcare from whichever vantage point we come. So I'm excited to have Nellie Vasquez-Rowland on the panel with us today. She's actually calling in from out of the country, and I want to thank her for extraordinary commitment to presenting at any point that she's given on these topics. One is the opioid epidemic, and that of the substance abuse epidemic overall, particularly what she observed during COVID-19, as well as opportunities that she thinks we can do this better. She's the CEO and founder of A Safe Haven here in Chicagoland. I want to thank Pat Meriwether-Argis for joining us. She's the CEO, Executive Director of Project Patient Care. She'll be talking to us about nursing homes and the opportunities for nursing home reform. And then Raul Garza, the President CEO of Aunt Martha's Health and Wellness, will be talking to us about children's mental health, behavioral health, and the care of children in the foster care system. So we'll have a pretty spirited discussion. You can use the chat to ask questions and engage with us. We'll do the best we can to respond to those as we go. And then I want to start out by talking a little bit about the maternal child kind of crisis that we're having in the city right now. Thank you, Deborah, for getting me on point. I'll take the next slide because they disappeared on me. So we could go to the next slide where we talk about some of the guide rails that So as we spent the last 2 years looking at a series of topics, as Lorenzo said, we covered, with several sessions, we brought together innovators, policymakers, thinkers, leaders, doers in healthcare from across the state. Several things kind of rose up as opportunities to improve the systems that we feel are broken and need really to be fixed, right? So one is that we're aware of opportunities and we take the opportunity to advance health equity, that we focus less on studies and start moving towards solutions that solve some of the issues that are before us, that we look at the chance to link innovative models across the city and the state. That was a part of our agenda for convening and making this open to anyone who wanted to join us. So we want the opportunity for you all to begin talking about things that are working well in your various areas and linking with others to maybe start to build actual systems, not just what's going on at your place, but how do we connect some of the work that's going on so that we have an opportunity for systemic support, intervention, and change. And then to educate us on, how do we and what policies we should be advocating for that make sense and also that help address some of these underlying inequities that we're all kind of dealing with on a day-to-day basis. We want interventions that are sustainable. So again, the opportunity to link, to build systems, to build systematic change, and to pragmatically intervene, or what lead to sustainable change that outlives COVID-19. A good example of that is telemedicine and Medicaid. And as of right now, the state is looking to maintain telehealth as a mode of delivery for healthcare services. So we entered into telehealth for Medicaid statewide because of the pandemic. And now the pandemic is moving through its various stages, but the state is going to continue telehealth as an opportunity to deliver services. So we created a sustainability opportunity. We leveraged what was going on, and now we are hopefully headed towards some really interesting systemic change opportunities. Good governance and coordination goes without saying. And then we want to make sure that we are adequately representing diverse leaders, particularly that represent the communities that are being intervened on and helped. We want to make sure that we're inclusive there and getting the best set of perspectives at the table. Next slide. And so as we move forward, these are some of the things that have sort of bubbled up. We'll continue to evolve this, and so you'll continue to see the convenings that we do reflect some of these, but also be responsive to what's going on, like in our land, in our city, state, and county right now. Opportunities to reduce systemic racism, improve health equity. We want to continue to look at opportunities to address the maternal health and morbidity crisis. We want to acknowledge and address the mental health crisis among youth, adults, seniors, and children. Opportunities to build human capital are going to be critical because we're going to need to build more capacity in our systems that are going to take us the next 10, 20, 30, 40 years. Again, we talked a little bit about diverse leadership, and then we want to make sure that we're looking at opportunities to promote disease prevention, and the example, chronic kidney disease is an example here, and then extend life expectancy. And that encompasses a broad set, if you will, of interventions here. So it can include things like nursing home and rate reform and nursing home reform, because we saw during COVID-19 the life expectancy for several populations impacted decrease, right? There was a lot of people that died in nursing homes. So there's examples under that are going to be long and not necessarily for this presentation. So I want to just talk a little bit about where we are with maternal mortality before we jump into the rest. My esteemed panelists who are joining me today. As I said, Nelly Vasquez-Rowland has joined us, Pat Merriweather, and Raul Garza. So we look forward to kind of moving through these topics. From a maternal child perspective, I want to just highlight a couple of things. One, we are in crisis. Over the past 20 years, several hospitals have closed on the south and west sides of Chicago in particular, and practitioners have retired, meaning they've either aged out, retired, or sold their practices, so that sort of widespread community access to entry-level OB care is just a little bit harder to find. The federally qualified health centers have done a reasonable job of trying to capture that gap, but we have really kind of one solution that we're dependent on. The community-based OBGYNs that were around when I was delivering my children 20 years ago are no longer there. They're either hired by large systems or, that's it. You're very hard pressed to find a practice in these communities that offers kind of comprehensive entry level OB care. For those who are able to seek care at our federally qualified health centers in particular, and maybe small sort of single practices that are very small and capacity challenged, I would say, when a woman needs more complex care, such as a level 2 ultrasound from a diagnostic perspective, or the attention of an MFM, a maternal fetal medicine specialist, she will have to travel. If she's on the south side of the suburbs, she may have to go all the way to Cook County, all the way to UIC, or all the way to Sinai. she oftentimes will need transportation in order to do that. So you then now enter another variable, which is transportation. And I have stories which happy to share with those later, but many of you probably know of these, where a person has to travel via group transportation all the way over to the west side, and then they have to wait to have their study done and then travel all the way back. So as a pregnant woman, please understand the level of stress that this will contribute to a woman's day. And if she has other children she has to worry about, this is an incredibly kind of unsustainable practice, if you will. And the opportunity to build out a facility on the South Side that women can access for the level 2 for maternal fetal, I think is a critical intervention. We must get that in place as soon as possible. One of the other issues, and I've taken this and spoken with HFS about this, is also that it depends on the health plan you're in. So the hospitals on the South Side will take certain Medicaid managed care health plans, but they won't take others. So that means if you have a health plan A, you might be able to be seen at University of Chicago or Ingalls. But if you have health plan B, you may have to go all the way to UIC or Mount Sinai. This really is, to me, this makes no sense. And I think this is a huge opportunity to look at what we call open networks when you have such a capacity issue in an area. So I'm recommending open networks here when it comes to Medicaid managed care to specifically deal with access in this regard. That means that if you have Medicaid and you are pregnant, if there's a facility on the South Side that is taking state dollars for Medicaid, that is getting all of the different benefits from the Medicaid tax, as well as the Medicaid booster for deliveries, that a woman should be able to access that facility no matter what managed Medicaid program she's in. So I want to stop there with my feedback here. I'm going to give us probably a D in this regard. I'm looking forward to the next set of data that shows us. Actually, I don't want to wait till then for someone to tell me that maternal morbidity and mortality is the same as it was measured last year when all the newspapers did a big story on it, or 2 years ago. I like to see us address that in real time now. One of the interventions I recommend is a cross-county work sort of task force when we see egregious things happening with women who are seeking a level 2 ultrasound or other needs in their quest for prenatal care, that we as a collaborative work across the county to address that. The IOMC did put into one of the transformation proposals a request for support for a staff person to staff such a working task force across the county. So we're still waiting on that funding to come through. In the background, of course, are high malpractice rates for OBGYN, right? The need for probably tort reform in this regard. And practitioners are concerned about the level of Medicaid reimbursement for those in the OBGYN field. So thank you. If you have any questions, I'm happy to consider those, or we can talk about at the Q&A period. So for maternal child health, I'm gonna give us a D, and we've made some specific recommendations that we like to see happen as we consider the opportunities to improve health outcomes in this population and with this particular situation. Nellie, thank you so much for being on today. Talk to us about the opioid epidemic, your thoughts and experience with it, as well as homelessness. There were 2 topics you were going to talk with us about today.
I'd like to thank you for putting this amazing webcast together. I think the topics that we're discussing here today are extremely timely and extremely urgent in terms of, fast tracking what could be emerging solutions for what the framework of the healthcare and the behavioral healthcare infrastructure needs to look like. You mentioned earlier about how it's exposed many of the gaps, many of the fragmented, services that are out there that are leaving so many of the most vulnerable behind, not getting easy access to healthcare, behavioral healthcare services. I mean, the list goes on. But I also want to take a moment to acknowledge that it has also exposed the things that worked. And I think we need to really pay attention, because this was something that could not have been predicted in terms of, the worst, humanitarian crisis we've ever seen in terms of this pandemic, and how it's affected almost every industry, every field, and especially the healthcare and behavioral healthcare field. And specific to the topics that I want to talk to everyone here today, it particularly showed the gaps in terms of the homeless services and in terms of the opiate epidemic, in terms of what's been happening even before the pandemic, in terms of, what I call the homeless and the opiate epidemics. Today, they are exploding, for lack of a better word. We have seen an increase of homelessness during the pandemic, chronic homelessness of about 34%, and unsheltered homelessness by about 21%. That's according to the National Alliance to End Homelessness. We've also seen a major surge in the number of people that are overdosing. For the first time in 2021, we exceeded over 100,000 deaths. And these numbers are only going to continue to get worse if we do not have a very intentional, strategic, integrated plan and framework to help prevent people from hitting rock bottom and dying, and from helping them from ending up on the streets. And everywhere you look right now, it's not your imagination. The numbers of homeless people living on the streets have gone up. And besides the fact that we are seeing a major increase in the opiate epidemic, we know that 40% of the individuals in this country were living in poverty and were one paycheck away from being homeless. And unfortunately, many of those, frontline workers, essential workers, people working in factories and places where they got laid off, are coming face to face for the very first time with homelessness. And I can attest to the fact that we are seeing that on the front lines at a safe haven. The number of people that are calling us tend to be right now more educated. In fact, aren't even suffering from any substance abuse issues, but are suffering from economic challenges and their families. So this is a new demographic of individuals that we've never seen before in this at the level of numbers that we are seeing right now, because we have seen it before. So with the pandemic, one of the things that the CDC required was for homeless organizations to decompress, which means they had to reduce the number of beds because of the fact that most homeless organizations, your traditional homeless organizations, have cots. They're basically in a church basement, or some open space, or called open congregate living, and where maybe 100 beds were laid side by side. And because of the pandemic, the CDC required homeless organizations that were following that model to decompress and reduce the number of beds so that they can have the 6-foot social distancing requirement met. For Chicago, that means that we had to reduce the 3,300 beds that we had before the pandemic, and we have not replaced 10% of those beds. So essentially, we went from having 3,300 beds, and we're currently at about 3,000 beds. Well, even before the pandemic, we were way below the number of beds that were needed. So in 2019, according to the Chicago Coalition for Homelessness and the HMIS numbers, which tracks the number of homeless, we had about 58,000 homeless individuals. That was back in 2019. So as I mentioned before, those numbers have gone up dramatically. So we have a once in a lifetime opportunity right now, I think, in terms of what we're going to do to really look at the data in terms of what worked, what didn't work. What can we take and scale in a way that's going to ultimately lead us and help us land with a true integration of institutional health with step-down programs such as behavioral health care and homeless organizations that are really meeting the needs of the individuals that are not only suffering from addiction, but today are even being impacted with COVID-19. And I'll talk a little bit more about how we responded to that in a minute. But ultimately, how we're able to connect them to an ecosystem or continuum of care that's going to be by design, assessing them, connecting them to coordinated services in a way that ultimately will help break their cycle of poverty, break their cycle of addiction, get them on, on a path to independence, whether that includes getting them to permanent income because maybe they're seniors or they're veterans that they may qualify for, or getting them into job training programs, jobs, and permanent housing. Now, A Safe Havens model has been around since 1994, and over the last 27 years, we've been on this path of really trying to create a vertically integrated ecosystem that by design accomplishes exactly those goals. So, but again, this is the first time where we've actually seen a sense of urgency and hopefully recognition that homelessness is truly a public health issue. And I know we have limited time today, so we're just going to kind of start to wrap this up, but please join us in March as we go into this with presentations and slides in more detail. But I can't emphasize enough how important it is to really consider this issue of homelessness with the lens that it truly is a public health issue. What we did in response to COVID-19, we knew immediately that the homeless were probably going to be on the bottom of the list of individuals that would qualify for getting access to healthcare services. They also were going to be the ones that were not going to be able to meet the requirement that the state mandated to shelter in place. As a homeless provider with having over 1,200 individuals in our care that are either in our transitional housing or supportive housing services, we knew that eventually people in our program would get diagnosed with COVID-19. And our biggest concern was, where would we put them? Where would they go? And where would homeless that are on the streets or at other homeless organizations go if they needed a place to isolate? And not only isolate, but get access to the type of healthcare that they need to help, obviously help them heal from COVID-19 in a safe way, but also take the time while they're in our care to connect them to the other assessment services of the social determinants of health that we call in a way that was going to allow us to discharge them to an appropriate level of care. So there's always been this slogan of treat them and street them, right? Where many individuals have gone, and entered the emergency room because they did have a behavioral health care issue, a substance abuse issue, they had an overdose, and then, of course, they go into the acute level of care, which is the emergency room, get detoxed, but there's nowhere else to send them for aftercare. And our, belief and goal over the years has really been working towards trying to connect hospitals with our type of care, for example, where they can actually get the ongoing treatment and other wraparound services that, again, we're going to lead them to their highest level of independence. So when the pandemic hit, it occurred to us that there needed to be that integrated approach that allowed us to have hospitals decompress, because they did need those hospital beds for individuals that were either homeless or couldn't go home because they could not isolate. So thankfully on April 11th, we worked very closely with Rush University Healthcare System, along with the Chicago Department of Public Health, to open up the very first COVID-19 medical respite that's co-located at A Safe Havens facility. On that date, we actually opened up 100 beds. And since we've opened it up, since April of 2020, we've had over 1,200 individuals, COVID positive individuals, not only get access to the healthcare services that they need, but also the other assessments that they needed, so that ultimately we can make informed decisions to discharge them to an appropriate level of care. I want to share a story of an individual by the name of Lydell. Lydell is a perfect example of someone that was homeless for 25 years, addicted to heroin, in and out of emergency rooms, in and out of prison for over 25 years. And it wasn't until he got COVID-19 that he ended up in Rush Hospital and was then discharged to the medical respite, the A Safe Haven COVID-19 medical respite. Upon discharge, we were able to take them into our programs, in our transitional housing program, provide access to all the services that he needed, which included ongoing treatment, education, job training. Today, he's employed and he's permanently housed. And we're super excited to share that we have many stories like that that are happening as we speak. So we believe that the pandemic is allowing us an opportunity to really think differently, with the idea that we have to truly treat the individuals for all of their underlying conditions and not do it in a myopic way, but do it in a way and not do it in a way that provides a patchwork of services that are never going to lead people to their highest level of independence, but to truly do it in a very intentional, what I call human infrastructure, which includes access to health, behavioral health care, economic development, and housing. And by doing that, ultimately, not only are we creating standards of care, but we're truly treating homelessness as an urgent public health issue. And then finally, I want to just mention to everyone here that we noticed with the CARES Act that when they did send out those emergency resources to every state from the federal government, that while healthcare organizations and nursing homes did qualify for financial resources and PPE supplies, and even were first in line for vaccines, unfortunately, homeless organizations were not considered part of that. And we feel that the organizations that are working on the front lines are the first to see these individuals that are suffering, but the last to get considered when it came to resources. So we've actually introduced a bill called HB 3949. And what that bill does is it allows for our state government to elevate homeless providers to become part of the critical infrastructure, so that in the future, whenever we have humanitarian issues, whenever there's contemplation for allocation of resources, that homeless providers are considered on par with the need and on par with the demand, which we are seeing, as we all know, more demand than ever before. But again,
Nellie.
I'm good, thank you.
Okay, no, that's outstanding. So we're gonna keep moving because we're starting a few minutes late. So we're gonna ask Pat if she could do 6 minutes instead of 7.
Sure.
And
Okay.
talk to us a little bit about sort of nursing home reform. And go ahead, Pat.
Yeah, and I think everyone that's in healthcare, especially that works closely with the older population, knew that we were in great danger when COVID hit. We knew that our most vulnerable were going to be subjected to great harm, and it was predicted. In nursing homes in Illinois, there was very little PPE that existed. At the initial periods of time, probably about 6 or 7 months, and some are still experiencing a lack of PPE. Congregate housing with most vulnerable populations put the nursing home population at risk. And in November 2019, you may recall that at that date, at that period of time, we were supposed to have infection control and preventionists in every nursing home, and that was turned away. Even though it had been legislated, it was pulled back. So again, many of us are saying, what if we had had the control and preventionists, the infection professionals in place, would we have had this volume of deaths? So when I talk about the volume of deaths, 87% of the deaths that have occurred in Illinois, and this is reflective of the nation too, are those 60 years and older. They make up 15% of the Illinois population, but 87% of all the deaths. And in nursing home residents in Illinois, and there's a map that CDC has on this, 14 out of 100 residents died due to COVID as of February 2nd.
Wow.
The nursing home residents represent less than 1% of the population, but 25% of COVID deaths. And when I say nursing home population, that does not include assisted living and other senior housing, because we know that they also experienced high rates of death. It disproportionately, as much as we're talking about age, there is a racism factor in here too, because the nursing homes that serve primarily Black and Brown populations or communities also experienced higher rates, disproportionate rates of death among their populations. We know when the vaccines went into place, they really did make a huge difference. We could see a sudden drop in the harm and death. but now they need boosters, and boosters not only for, and vaccinations not only for new residents that are coming into nursing homes, but ones that have been there, they need the boosters. And it's disproportionately, if you look at the maps of Illinois, it's disproportionately slanted towards more what I would say white and higher income areas. So you can see on the south and west sides of Chicago, the percent of residents and staff that have been vaccinated, or as I like to look at, the non-vaccinated, and the disparities still are on the south and west sides of Chicago. I think this is a national issue, but I can't excuse it because it happened in our backyard. So I really think that we could have done much better. In terms of staffing, the adequate staffing levels are a national issue. In nursing homes, they have been an issue for as long as I've been in healthcare. We've been talking about this. When I look at the hours that are spent with any resident, the nursing home staff hours, and this isn't just at RNs, it's all staffing. Nationally, it's about 3.46 at 3 hours, 46 minutes. And in Illinois, we're a little bit less. What is also concerning is the turnover rates nationally. Now, just think if you're running your business, if 52% of all your staff turned over every year, how that would affect you and how that would be very difficult to manage any type of improvements or changes. And so nationally, it's 52%. Illinois, it's 51%. And what's different about Illinois too is our administrative turnovers are much higher than in other parts of the country. Last week, CMS put all this information. So if you're doing what's called Nursing Home Care Compare, that information is available for every nursing home, every facility in the United States. Now, I do want to talk about that. And it's hard to say there's any good coming out of, COVID, but one of the sidebars is this issue of nursing homes has remained on the radar. So there's a focus on community care and transformation, building resident, family, and community councils. So the reason behind community councils is because they are the voice of continuity and sustainability. They will be there and be monitoring and working with legislators, elected officials, people that want to make a difference and make sure that the residents are protected. The importance of communication is critical. We know there was isolation, depression, self-induced suicides that occurred because the residents were left alone for over a year without interaction. Nationally, this was national, it just wasn't Illinois. I volunteer with Rotary. We provided iPads to about 264 nursing homes in Chicago and the safety net hospitals. And just this past session, here's a win. There was legislation passed that anytime there's an emergency, that the hospitals and nursing homes must provide virtual communication with the family and the caregivers. And Senator Collins went a little bit further and these were unanimous support, bipartisan support, unanimously. By January 1st, 2023, every nursing home must provide virtual communication just as if they are providing in-person visits. So there's going to be the virtual visitation, which will help so many residents and their families stay connected. And lastly, we know there's a great deal of interest in providing funds for nursing homes. And we, looking at the residents, and if you get a chance, please visit your local nursing homes to get a sense of what's going on. But they do need help, but we need accountability for that. If we're giving money to increase the staff payments, we need to make sure that there's accountability built into that, because we don't want it to continue. The United States for nursing homes is largely a for-profit I hate to use the word industry. I like to view it as it's about people, it's about nursing home residents, it's about loved ones that people have in nursing homes because of their needs. But we need to make sure that it goes towards the right resources and that there is accountability and improvements are being made. So in terms of, this is a national issue, I give the nation a D-, but I have hope. And so I'm giving it a B because I do think change is on the way, both in terms of addressing ageism and racism in nursing homes.
Pat, thank you so much. I know you covered a lot of material there that we're going to capture just for everyone to know in a document, right? So we'll be sharing this with you. But I agree that there are opportunities to improve. Will we grab those and move forward? Because there's some legislation on the table in Illinois now that would improve accountability. It would, fund some staff payment improvements and other infectious disease processes improvements. That could be a huge step forward. So thank you so much.
It would be a wonderful step forward. But
Indeed.
we need to make sure it happens.
Thank you, Pat, and also for pointing out that honestly, the bulk of people that died in nursing homes, they were actually Black people.
Yes.
So there's a moral imperative, if you will, of humanity here that I'd like to see us address. Like I said, this hour is moving fast. We want to leave a few minutes for questions. So Raul, you've got the next 7 minutes. I'm going to turn it over to you.
Okay, Dr. Whitaker, thank you. Let me just say that I have great respect for the work that Pat and Nellie do at their organizations and with their organizations. My honor to serve on the panel today with everyone. So I'm not going to spend a lot of time on what we've been doing with our own pandemic experience. So that slide's there. People want to access it, it's available. Let's go to the next slide, please. I think this is critical. This was one of the major resources, valuable resources that came out of, or that we experienced during the pandemic and hopefully comes out of the pandemic, and that's the leveraging of telehealth. At Aunt Martha's, even before the pandemic, we had been the pioneering federally qualified health center to really innovate telepsychiatry 15 years ago. And so when you do the right things, for the right reasons, 15 years ago, it turns out that it's a critical resource today and has been over the last special years, especially as it relates to mental health support. So prior to the pandemic, you can get a sense of what our telehealth activity was at about 3,400 patients, and then that resulted in about 10,000 visits. Look at what the increase was over the past 2 years, just incredible reliance on telehealth. Now, a lot of that was certainly primary care visits that were appropriate to be provided through that technology, but a lot of that was also telepsychiatry and teletherapy. And why that was important is because prior to the pandemic, our no-show or cancellation rate would be about 40%. The last couple of years, it's been like 6 or 7%. So it really gives you the sense that the patients were much more comfortable having this type of visit done at their home through the technology. And I won't read the slide to you, but you can just kind of get a sense of, what's been happening on the national level as well. Well, I want to spend my 5 minutes, I think I probably have left, Cheryl, I hope, is around the current crisis that you may have seen in the news recently, and we'll go to the third slide, and that centers around children that are in the Illinois Department of Children and Family Services that are beyond medical necessity and unfortunately stuck in psychiatric hospitals. So what ends up happening is the youth might be placed with a provider or a foster parent. The youth disrupts because the youth has a high behavioral health acuity. The youth is assessed, the child is assessed, and then they're placed in the hospital for stabilization. The hospitals are effective at stabilizing the youth, and then the youth are ready to be placed back with the organization or, let's say, with the foster parent. What ends up happening is that those entities aren't able to support the youth because of the youth's acuity. And so let's just take a step back and understand what's been happening over the last several years. In 2018, suicide was the second leading cause of death for people ages between 10 and 24. And that's why it's so frightening to consider what it means that mental health related ED visits have increased by 24% for kids ages 5 to 11, and then 31% for kids ages 12 to 17. And those are statistics that are representative of children in the general community. So not necessarily just DCFS, but the at-large situation with children, period. And so when you localize this down to the DCFS population, it really comes down to a lack of having placements. And so over the last several weeks, the DCFS director, Mark Smith, was hit with 3 contempt of court orders because the inability to place 3 children that were stuck in a psychiatric hospital, or 1 child was found sleeping in a utility closet of an office. So that combined with anywhere between 45 to 55 children currently today are stuck in psychiatric hospitals. So once the 3rd contempt of court order was issued to Director Smith 2 weeks ago yesterday, the department called me up directly and said, hey, we've been instructed by the governor's office to contact you. Is there anything you can do to help with this issue? And so currently we operate what's called the Integrated Care Center that's located in Bronzeville. And it serves as a residential placement facility that houses and cares for 33 of the most acute children in the state's care. Over half of the children that we take in are either coming from other organizations, coming out of the detention system, juvenile detention system, or coming out of the psychiatric hospital placements. So it serves as the one facility that provides care, the only one facility that provides care to the most acute children in DCFS's care. In fact, the children average anywhere between 7 to 10 diagnoses. So think about that. I mean, think about that kind of acuity. So my team and myself, we got together over the last several weeks, and we built out a concept to really add more capacity at the current facility that'll allow for 20 more beds that'll go to serving this population. And then we're building out an 8-bed drop-in center, or I'm sorry, an 8-bed program that we can move children that are appropriate for that placement to go in there. So in effect, we're coming to DCFS's response with 28 beds that will hopefully help cut the problem in half, with the 53 beds or 53 children right now that are in psychiatric placement beyond medical necessity. So I think what's happening is you have this combination of the former administration having reduced 500 beds that were available because the concept back then was really to try to deinstitutionalize children, put them in a foster care setting where they can be supported by community resources. I mean, similarly to what my colleague Nellie was speaking about, having this integrated approach to care. Problem is that the children I'm speaking of can't be cared for in that type of setting because of the level of the acuity that they have. So having innovated this integrated approach to care three and a half years ago really brings our expertise as a federally qualified health center, and in fact, the only one that is licensed by the Illinois Department of Children and Family Services, together with our child welfare experience to really effectively support these kids. About 14 months ago, I commissioned the Healthcare Management Associates, so consultants and often involved in research, to come in and study the program, to study the effectiveness of the program. And certainly I would make that available for anybody that's interested in it, because the study was just published last week. It's a 42-page read. It's a little dense in parts, but a little technical as well. But it really goes towards validating this approach to care, this model that we've been providing services to the state with. And I think sometime in April, we'll hold a half-day conference where we'll talk about integrated and value-based care, and then also talk about that study and have HMA come in and speak to the methodology and the outcomes that were very positive in terms of reducing hospitalizations, in terms of increasing medication compliance, in terms of reducing acts of aggression by the youth or unusual incidents, and significantly reducing elopements and runaways, which is what these kids were experiencing in other placements. So really proud of that work. And I met with Speaker Welch of the House just last week, talking about the work we're doing and talking about our response to the DCFS crisis. And he asked if I could participate in the expert witness hearings that'll follow the one that happened last Friday, that are focusing on this issue to really enlighten people that there are models that can work serving this population. So look for that. Happy to invite stakeholders are involved in this discussion today. And I'll stop there because I know we're at time. You want to leave time for Q&A. So thank you for the opportunity, Dr. Whitaker.
No, definitely, Raul. I'm hopeful. I don't want to put you on the spot, but IMC would love to co-sponsor such a convening and make the Power of Our Network available. I think the more, what I'm frustrated by, Raul, is we reduce children to a clickbait where we make some dramatic newspaper article, right?
Yeah, right.
And so it ends up in the paper, but no one's solving the issue. And so this has been going on for quite some time, right? So the fact that you brought us to this point, I'm just excited that we're moving forward to a solution and that you've been empowered. And you've also been appropriately, I hope, compensated to put the resources in to build the right kind of program. So it sounds like that's been a good opportunity.
No, I think what's different about this administration, both DCFS and the governor's office, is that they have said, look, and I think I said it even 3.5 years ago, and to give credit to the director at that time, BJ Walker, because it was she that got to a place where we could innovate this program. But look, it all comes down to the cost of care. It comes down to two concepts, right? The cost of care being covered, but then also we have to be able to demonstrate value back. And the value needs to be defined, I think, in two ways. One is the patient, or in this case, the child, getting healthier in our care. So what did that child look like before they came through Aunt Martha's doors, let's say a year ago? How's that child doing a year later? Can we demonstrate that the child is healthier? Number one. Number two, are we lowering the cost of care? So, and that speaks to what I just mentioned about the HMA study. Hospitalizations are reduced, increase in medication compliance, et cetera. So no, I think there's an open-mindedness, but I think the provider network has got to be ready to reimagine and re-engineer the work in a way that it does what it's supposed to do for these kids.
I know you won't have time to go through it with us today, but I did have a question about this sort of the therapeutic residential environment. Is it good for kids to be concentrated together who are suffering from similar kind of acute or maybe even severe?
Yeah, I think so.
Yeah.
So because, they're with peers, and the peers are often experiencing the same diagnosis, and you want to try to make the setting as family-like as possible. And so often peers see each other as siblings in a lot of ways. And I think that's healthy for the evolution of treatment for these kids.
So I'm going to let you have the last words, Raul, to take us out and tell us where you think we're going. We got a couple more minutes. Please take it over. And thank you all so much today. I enjoyed working and talking with you.
Thank you. So let me just say that I want to personally thank both Nellie and Pat for their presentations today, and Lorenzo for the introduction, and then Cheryl for moderating. So we want to remind everyone that the IOMC, Institute of Medicine Chicago Healthcare Awards are open. The nominations are open this Monday, and those will go through May 4th for all submissions. So please go to the IOMC website for more information. And I want to thank again all our sponsors for your generous support of the Institute of Medicine Chicago. and the commitment of our board of governors, which is a very committed group, very passionate, very high functioning. I mean, just movers and shakers in the healthcare industry, and to all our members and colleagues for their support and participation, not just today, but consistently and always. So over 1,000 people have attended these virtual sessions over the past year. So I think it says a lot about our ability to engage and hopefully help raise awareness about the topics we speak from. And so that number is a record for IOMC, and that's under the great leadership of Dr. Cheryl Whitaker, who's always had a strong vision for making sure that IOMC is giving value back not only to its members, but to the general public about critical topics. And it really hasn't been a more critical time, I think, than what we've experienced over the last 2 years. And it's, you know, it shouldn't be a secret that these efforts over the last 2 years were really our first entree into doing virtual sessions. So more about that in the future. No need to stray from that approach. Please follow us on LinkedIn, check out our blog, and visit the IOMC website for more details. I'm going to close it out here by just wishing everybody a great day, a fabulous weekend. Stay healthy, stay safe, and thanks for being with us today.
Thank you. Thanks, everybody. Talk to you guys soon.